There is another study to understand the clinical practice of CAS in Hong Kong. It is also done by the same research team. First of all, I would like to point out that the survey study provides valuable information of clinical practice and give direction for research investigations. In 2003, Forrest asked practicing speech and language pathologists about the clinical features of CAS. 6 characteristics were mostly reported among the respondents. Apart from knowing the clinical features used by the clinicians, a survey study was conducted to understand how the clinician developed their CAS expertise. The results showed that clinicians developed their CAS expertise mainly based on continuing education program. The respondents ranked inconsistency as the most indicative features. Treatment approaches used by the respondent were also asked. The descending order of responses were reported here, from left to right. Recently, clinical managements of English-speaking countries were surveyed. The result found that the SLPs in Australia and New Zealand treat CAS with an eclectic approach, with Nuffield dyspraxia program is the most popular interventions. Lower section frequency was also found. The respondents were asked about the barrier hindering evidence-based practice. Responses included lack of time to explore literatures on CAS and the difficulty interpreting statistical analysis. Similar survey has also been conducted in the US and Canada. The results show that the SLP in this country also use an eclectic approach to treat CAS. The most commonly used approach includes Kaufman, DTTC, and prompts. The barriers hindering evidence-based practice includes the time constraints, poor access to relevant articles or reports, and limited high-quality research. The purpose of these studies was to examine the clinical practice of CAS among the SLPs in Hong Kong, especially to understand the knowledge and experience, the assessment, and treatment of CAS. These surveys contain an online questionnaire with 48 questions in 4 sections, including the demographic information, the knowledge and experience, the assessment and diagnosis, and treatment. 20 minutes were expected to complete, and SLP who work with Hong Kong Cantonese speakers were invited to participate. Finally, this question has been opened for 7 months. Results. There were a total of 77 responses. The year of clinical experience of the respondents were 5.8 years. The figure on the left shows their self-description about the understanding of CAS. Most of the respondents rate their rates as either a little or fair understanding. The figures on the right show the respondents' previous training on CAS. Most of the respondents received training from their professional degree and self-instructions. And about 35% of the respondents learned CAS from continuing education program. This pie chart shows the number of children with or suspected with CAS that respondent had worked with. It shows that only 53% respondent had worked with children with CAS in Hong Kong. About 43% of the respondents have seen 1 to 5 cases, and there were 2.6% of the respondents had seen more than 20 cases. A correlation analysis was done here, and the results showed that moderate to large significant positive correlations can be found between the number of CAS cases and their self-descriptions of the understanding of CAS. Regarding the assessment task used, there were 32 respondents who had experience on diagnosing CAS in children. 100% of these respondents used imitation and or production of polysyllabic words and conduct speech and language sample. DDK tasks were also used by more than 70% of the respondents. Regarding the diagnosis, no standardized tests or quantitative measures were reported by the respondents. Therefore, perceptual judgment of clinical features become the main concern. The results showed that 4 respondents did not use any checklist and 5 used existing checklists, including the Strand 10-point diagnostic checklist, Archer's 3 consensus features, and Wong's 29 clinical features. 20 respondents used their own checklist, and 3 respondents used both existing and their own checklist. There were 20 different sets of clinical features and diagnostic criteria used by our respondents, and there are 27 different clinical features identified. Some features were used by more than 50% of the respondent, including the non-speech or speech grouping, inconsistent errors, and increased errors on increased syllables or sentence length. Some of the features were used by more than or equal to 25% of the respondents, including the poor DDK performances, difficulty in volitional speech or non-speech movement than in automatic counterparts, reduced accuracy on sound or sound imitation, and articulatory errors. Another question asking the respondent about how the 7 identified clinical features is important in making a differential diagnosis of CAS in Cantonese speakers. The results show that most of these clinical features were rated towards very important in making diagnosis, except the lexical tone, which was mainly rated at 4, which is neutral. Regarding treatment, most of the respondents provide 1 or less than 1 session per week, and the duration is about 35 to 50 minutes. About the structure of the treatment delivery, most of the respondents adopt the use of within-section block treatment. That means speech production and other areas were practiced in the same sections. Most respondents arrange 50% of time for speech production practice, followed by 30%. For the 5 respondents who have adopted the use of between-section block treatment, the block can be 1, 3, 4, 5, and 18 sections for speech production practice. Regarding the treatment focus, most of the respondents focus on segments followed by supersegments, and there is a small proportion of respondents treat both segments and supersegments together. In the follow-up question about the priority of treatment items, the respondents treat vowels and diphthong first, followed by initial consonants. For the supersegment, the respondents treat co-articulation first and then lexical tone. Regarding the treatment approaches, prompt is the most commonly used approach among the clinicians in Hong Kong, followed by DTTC. It should be noted that the percentage of using prompts is about 55%. For other approaches, traditional articulation approach was used by about 60% of clinicians, followed by the talk-to oral placement therapy, which is about 50% of the respondents. Discussions. This study aimed to understand the clinical practice of CAS in Hong Kong. There is only slightly more than half of the respondents have worked with children with CAS, and the self-description of the understanding of CAS is correlated with the number of cases that the respondents have worked with. It is also observed that young SLP learn CAS from the university training and self-instructions, and experienced SLP learned from the continuing education program. Regarding the assessment, there is no report on the use of standardized assessment or quantitative measure which is consistent with the scoping reviews that I have presented yesterday. It was observed that cause-effective tasks were commonly used. For example, the imitation and/or productions of polysyllabic words and speech and language samples. It is also known that the tasks that are short but informative about speech motor controls were also used mostly by the respondents, for example, the DDK task. For the diagnosis, CAS diagnosis was mainly made by the perceptual judgment based on the SLP own checklist. It raised the concern about the validity and reliability of the diagnosis. In addition, lexical tones remain neutral in making a differential diagnosis, although preliminary findings of lexical tones errors were reported in children with CAS, especially speaking Cantonese. Also, it was observed that 29 clinical features were underused. Only 1 out of 32 clinicians were used. There is a gap between the research and clinical practice. This may be due to the fact that the list of features is not yet validated and some features are uncleared. For example, the poor treatment progress, slow progress in learning new consonants or vowels, and better quantitative skills than expressive language skills. the better cognitive skills than expressive language skills. Regarding the treatment, low section frequency and short section duration were observed. The CAS evidence-based treatment program were not commonly used in Hong Kong. Instead, the commercially available treatment were mostly used. This is consistent with the previous study in which continuing education program has higher influences on clinicians' practice. An interesting finding was also observed. Although the lexical tone errors were neutral in identifying CAS in children, clinicians tend to treat it early. It is possible that the lexical tone errors affect intelligibility and overall communication very much. Partial implementation of evidence-based treatment is also noted. This shows that this is an universal phenomenon in SLP practice because similar findings has also been reported in other survey studies. Difference from other survey studies, the barriers include the limitations of section frequency, the presence of possible coexisting condition in the clients, and understanding of the treatment approaches was reported by the respondent in our studies. Here are the references of these studies. Thank you very much, and I'm pleased to be here to answer your questions. Thank you.